So, Milind, we start with the RKM, eh?
Yes, sir.
Okay. You have the presentation, or they will have their presentation on their laptop?
Sir, I'll be sharing some of their presentation. The others will be sharing their own.
Okay. So today we will be having surgical audit at Ramakrishna Shapadishan, Bhivan Institute of Medical Sciences, and also MRBH Hospital. This will be today a brief outline. We'll not go into the very depth, but as RKM is joining in this audit, we like to have this audit, and I would request other PGTs working in other district hospitals also can have similar audit discussions, because this is also a part of DNB teaching program. DNB team includes that you should discuss your surgical audit and make a surgical audit. And this audit is a general audit. Actually, audit also should be specific audit, like audit for infection, audit for bile duct injuries. So it can be like that. But initially, you are starting with this general audit only. So you start with the Ramakrishna Shapadishan, where they have 4 units. 1A, 1B, 2A, 2AB. So start with the audit presentation of 1A unit. So you can share your screen and start.
Thank you. Thank you, Madam.
Hello?
Yes, please.
Yeah.
Who is presenting?
Yes, sir. Surgical
Sir.
audit for
So Dr. Rooplekha will be presenting for Unit 1A.
Okay.
Rooplekha, you are supposed to tell your name first.
yes, sir.
Yeah.
Okay.
So myself, Dr. Rooplekha Ghosh. Good morning, sir. I present that surgical audit for January 2023 for Unit 1A General Surgery, unit under Dr. S.M. Bhattacharya sir, Dr. S.N. Basak sir, and Dr. S.N. Gupta sir.
Yeah, proceed.
Our outpatient summary, total OPD days 8 in the month of the January, total admission days 9, and total OPD patient 247, including the male 111 and female 116. OT summary, total number of elective OT days, number 7, total time planned in OT in laparoscopic surgery 18 hours 35 minutes, in open surgery 11 hours 50 minutes, time in the minor OT 30 minutes, and the time in the emergency OT spent 3 hours 30 minutes. Total elective admissions 35 in number, including male 10 and female 25. Elective OT done 20, among which 5 male and female 15. Emergency OT done 3, among which 2 male and 1 female. Minor OT done 2, 1 male and 1 female. Mortality none, and morbidity 1, which one is male. Including the hepatobiliary, pancreatic, and splenic surgeries. Chronic calculus cholecystitis was admitted. Laparoscopic cholecystectomy done in 11 patients, among which 1 was male and 10 was female. Chronic calculus cholecystitis patient undergo open cholecystectomy in 1 female patient. In hernia and groin surgery, we admitted 2 inguinal hernia patients who undergo mesh hernioplasty. 2 were male, 1 incisional hernia, and 1 incisional hernia which was female, undergo mesh hernioplasty, and 1 umbilical hernia, which one was male, who will undergo mesh hernioplasty. In breast and endocrine surgery, 1 fibroadenoma patient admitted who has undergone excision of fibroadenoma, and 1 breast shape patient admitted who has undergone modified radical mastectomy. In emergency operations, we admitted pylonidal abscess, female patients undergo incision and drainage of the abscess. 1 foreign body granuloma, male patient undergo excision of foreign body granuloma. 1 male patient sigmoid valvular came at emergency with sigmoid volvulus, and he was undergo exploratory laparotomy followed by Hardman procedure, and one patient admitted with diabetic foot, and he was undergone disarticulation of the third toe. Among the minor OT, one capillary hemangioma of the little finger, excision was done. She was a female patient, and one male patient was admitted with sebaceous cyst at forehead. Excision was done. Among the conservative management, we admitted one female patient with acute gallstone pancreatitis. Conservative management was done. Two patients with acute calculus cholecystitis, one male and one female. Conservative management was done. In choledocholitis patients, we admitted for ERCP and stenting procedures. Two were female. In case of a follow-up case of post-ERCP and post-laparoscopic cholecystectomy patient, one patient was admitted for stent removal through ERCP. 5 patients was admitted for follow-up the gastrointestinal carcinoma and breast carcinoma for chemotherapy procedure, and one patient was admitted with gastric ulcerations, undergo conservative management, and one patient with admitted with diabetic foot ulcer. He was also undergo conservative management. There is no mortality in our unit in the month of the January, and one morbidity was present. A patient, 70-year-old male, came to emergency with abdominal distension and obstipation for 2 days. He was a known case of COPD and hypertension. Preoperative chest X-ray, ECG, and routine blood investigations, along with the straight X-ray, whole abdomen, and supine and erect done. In the suspicious of having obstructions, CCT whole abdomen was done, which confirmed the diagnosis of sigmoid volvulus, incomplete rotation, along with the edematous valve. Saturation was maintained between 93 to 94% at room air. A consultation with the chest medicine department was done preoperatively for COPD. Emergency operation was done, exploratory laparotomy followed by Hardman procedure, but patient was not extubated due to the altered ABG analysis and low saturation. Patient was shifted to ICU that day, and extubation was done on the next day. Patient was monitored in the ICU for 1 day, and after extubation and shifted to general ward. There is no need of oxygen support, and patient is maintained his saturation between 93 to 94% at room air in general ward. There is no wound infection and no post-operative any complications present, and patient was discharged at POD 7.
Okay, Sileka, if you start with the morbidity part, in
Yes.
this sigmoid volvulus patient, how was the plain X-ray of the abdomen? Because most of the volvulus we diagnosed by a simple clinical examination
Yes.
and plain X-ray.
Plain
What was
X-ray.
the finding in plain X-ray? You
Sir,
got my
in
point? Yes,
it's straight X, sir.
yes, yes.
Sir, there is distended large gut.
No, no. If there is classical feature of sigmoid volvulus,
Yes, sir.
Why
Coffee
do-
bean sign was present.
so why did you go for a CT scan of this patient? What is the idea? Because if the patient has got a classic feature of sigmoid volvulus on plain X-ray, I don't think there is a need for a CT scan, because you see, you cannot give contrast. If
No, sir.
you have a obstruction, it's not possible to give a contrast.
Good morning, Makhanda. There was no,
Yes, yes.
it was not a typical sigmoid volvulus, which is
Okay.
the actually dilated loop of the large gut. Actually,
Acha,
we
acha.
can see the dilated loop, but it was not the coffee bean, which was the typical case. That's
Okay.
why we were forced to do one CT,
Yeah.
and we have tried to give the rectal contrast only, just to see whether the contrast is going, as because it is suspecting, we are suspecting the contrast is going above the sigmoid colon, within the sigmoid colon, rectosigmoid junction. So
Okay.
that's why we have done in CT along with the rectal contrast, which showed that there is narrowing and the twist, and a little bit of contrast has gone. But even then, there is a huge dilatation, patient pus stool, ultimately little bit, and followed by again persistence of the distension. So we have taken decision better to explore abdomen and have a look what is there. And ultimately, after exploration, it is shown that yes, it was an one turn, at least 1.5 should be there, and there is a partial obstruction, and gut was distended with edematous valve.
Okay. Okay, fine. Regarding the breast cases, you have shown 2 breast cases. One is
Yes, sir.
fibroadenoma.
Yes,
What
sir.
are the indication? What was the indication for surgery in a patient who was having fibroadenoma? What is the patient profile? What is the size? Because most of the fibroadenomas regress spontaneously. What are the
Yes,
indications
sir.
for surgery in this patient?
Sir, for cosmetic purposes.
How was the size?
No, sir,
Sir,
is not asking
greater than
cosmetic
3
purpose.
centimeters.
What is the size? If it is less than the 2.5 centimeter or less than 2 centimeter, it is not. It is of no use removing the fibroadenoma. Rather, you are destroying the breast tissue. So, as because it was more than the 5 centimeter and it's a
Yeah.
small breast, so that's why we were bound to remove
It's
the
a giant fibroadenoma.
yeah.
What are the breast cancer patient staging? Is it a MRM? What are the clinical staging?
Sir, clinical staging was T3. Sorry, sir. Clinical staging was T2, N1, M0.
T2, N1, M0.
Yes, sir.
Why did not you consider breast conserving surgery in this patient? If the lump was T2, then what was the point that gone against
Sir,
breast conserving
patients,
surgery?
considering sir patient's age, number one, and the sir all suspect axillary lymph node dissections was done, and the breast mastectomy.
No. Axillary dissection you can do even with the BCS. My point is, now the people are saying that result of BCS and MRM is comparable, and there
Yeah.
are some situations where you should consider for BCS. Even if it's a T2 lump, if you think of doing a BCS, you can give neoadjuvant when in T2 tumors. But you see, age is not the criteria to decide for BCS versus MRM.
Hello? Hello?
Yes.
Hello.
Dr. Bosak,
Mahunda,
yes.
Bosak. This
Yes.
patient is a 63-year-old lady who was a nursing staff of Kothari Hospital and
Yes.
in a very financially poor shape. She approached us and she personally decided, because it is T2, but it is more or less 5 centimeters in size, big tumor in a big breast, and it was a large operable breast cancer, large operable.
Okay. Fine.
And we have discussed the issues, and she didn't opt for radiotherapy and other things. Other things. Although she had a Sastro Sati card, we operated in Ramakrishna Mission under the purview of Sastro Sati card, and she is fine. She developed a seroma after in a second visit, and we have started her on chemotherapy with a Sastro Sati card in Ramakrishna Mission. She is otherwise fine. Actually, she is a nursing staff, and a whole lot of the accompanied persons, relatives and family members are more or less nursing staff, and she opted for herself because she doesn't want to go for any fancy surgery. And at the age of 65, I think it is justified. But your statement is also justified. For all young patients, we should offer a option of BCS. But before that, I think we should counsel them that after the BCS, they has to go for mandatory radiotherapy. This part is lacking in many of the postings whenever the patients come to us. But we have to offer them the full range of treatment what we are going to offer in BCS. I am very happy that you have raised the pertinent question that BCS should be promoted from the surgeon's point of view. It is a fantastic point nowadays.
That depends on our counseling also. How do you counsel the patient?
That counseling should be a pertinent part, and it may take half an hour to counsel the patient, but we have to. It's good. And all the students must emphasize this, as Professor Saha said, and you should keep it in your mind as we do it in the day-to-day OPD with the family members. Thank you. Thank you.
Dr.
Over.
Bosak, any comment?
problem in our hospital is like that. We can provide in the Sastosati card chemotherapy, but for the radiotherapy purpose, they will float in the in the Calcutta market. So no one will give at the earliest. So this is the problem in our hospital. Occasionally, we are forced to do that. And whenever is patient asking, then yes, breast conservative surgery should be done. But problem is the radiotherapy, we have no radiotherapy unit, so we shall have to send it to other unit. So we did 1 or 2 cases, but problem is there, they are moving from one hospital to another hospital and they are not getting the facilities. That is the
Now,
another
CNCI.
problem in our
What about
hospital.
the CNCI is coming up? CNCI has got a good radiotherapy facility now. CNCI at Rajarhat campus.
Okay. Okay. That is a good
Yes.
one. If it comes up, then it's okay, fine. Next time onwards, we will think of in that way.
Okay,
Thank
thank
you.
you. We pass on to the next presentation. So, Unit 1B.
Sir, for the next presentation, Unit 1B, I would like to invite Dr. Swaroop, who will be presenting the audit.
Okay, fine. Dr. Swaroop. Swaroop
Good,
Satra.
so good morning, sir.
Yes, yes. Please.
So good morning, respected teachers. I'm presenting the surgical audit for the month of January 2023 for Unit 1B of General Surgery under Dr. Pradeep Sengupta sir and Dr. Sumit Kumar Hajra sir. There were total 8 OPD days. Total admission days were 6, and total OPD patients were 237, among which old patients were 115, with 65 male and 50 female, and new patients were 122 with 69 male and 53 female. Total number of elective OT days were 5. Total time in planned OT 10 hours and 5 minutes for laparoscopic and 6 hours 55 minutes for open operations. Total time in minor OT is 55 minutes. Total number in emergency OT is 30 minutes. Total number of morbidities is 1. Among the elective admissions, total 18 admissions were there, among which male and female are 9. Both are 9. Emergency admissions were 5, with 1 male and 4 female. Elective operations were 16, among which 9 were male and 7 female. Emergency operations were 1 male, and 3 minor operations with 2 male and 1 female and 1 morbidity. Among the elective admissions, in the hepatobiliary, pancreatic and splenic surgeries, for chronic calculus cholecystitis, 8 patients underwent laparoscopic cholecystectomy, among which 5 were female and 3 male. In hernia and groin surgery, 1 inguinal hernia patient underwent Lichtenstein tension-free herniaplasty. In the gastrointestinal and perianal surgery, there was one perianal sinus tract excision of 1 male and 1 female with internal hemorrhoids underwent open hemorrhoidectomy. Among the breast and endocrine surgery, for an invasive lobular carcinoma of left breast, modified radical mastectomy with axillary clearance was done. Among the other elective admissions, there was a patient, male patient with sinus tract in the anterior abdominal wall, for which excision of sinus tract was done. 1 patient with multiple sebaceous cysts at the scrotum, for which scrotoplasty was done. And there is one recurrent ecrine poroma over scalp region, wide local excision was done. And 1 mole over left nasoorbital fold, the wide local excision was also done for him. 2 other patients were also admitted electively. 1 patient with colorectal cancer with multiple liver mets. After consulting the oncology, first cycle of palliative chemotherapy was introduced, and a follow-up case of modified radical mastectomy patient underwent first cycle of chemotherapy. Among the emergency admissions, 1 acute calculus cholecystitis was managed. 2 female patients with acute calculus cholecystitis was managed conservatively. 1 patient with acute pancreatitis was managed conservatively. 1 perianal abscess was drained, incision and drainage was done, and a follow-up case of a female patient with pain abdomen in a follow-up case of emergency laparoscopic appendectomy managed conservatively. Among the minor operations, 2 patients, 1 male and female, for which excision of sebaceous cyst was done, and 1 male patient with acute paranoia, incision and drainage was done. There was 1 morbidity. This 27-year-old lady, a private employee, presented with pain abdomen in a post-operative case of emergency laparoscopic appendectomy, who's 18 days back. was HP was came out acute appendicitis. She was discharged on postoperative day 2. She presented with intermittent dilating, non-radiating lower abdominal pain. Her port side scars were healthy. Abdomen was soft, non-distended with mild tender lower abdomen. There was a history of paravaginal whitish discharge. On radiological imaging, USG and CCT, it revealed hepatomegaly, few subcentimetric lymph node of 6 to 9 millimeter in right iliac fossa region and bulky uterus. Blood reports were normal. Urine reports shows pus cells 4 to 5 with no growth in culture. She was managed conservatively. Gynecological consultation was done, opinion taken, and discharged with the advice of gynecology OPD meet after discharge. Total number of hospital stay was 6 days. Thank you, sir.
What do you think, Saurabh? What was the cause of this pain that patient got admitted again?
Sir, as the patient was operated in an emergency basis, there may be some underlying other causes also possible, like gynecological causes or urological causes can be there. Or in what we suspected actually from surgical aspect of view, in a post-op case of acute appendectomy, there may be some residual abscess or some residual points, surgical.
What do you think? What is the incidence of intraabdominal abscess following lab versus open appendectomy when it is higher?
Sir,
lab versus open intraabdominal abscess is common in which situation, lab or open?
Sir, laparoscopy.
Yes, and rightly you have done a CT scan. A CT scan, patient admitted again with a pain abdomen. Ultrasound is not a reliable investigation. One should do a CT to exclude. We have seen a good number of patients with collections which need drainage. So patient admitted with the pain again should be investigated thoroughly, and a CT is mandatory.
Yes.
Okay. What about that CA breast? What is the clinical staging?
Yes, sir. Sir, actually the critical staging was T2N0M0. Actually, if you go to the past history of it, the patient after two-cut biopsy, when it came as this fibroadenoma, the patient has underwent lumpectomy.
Oh.
On lumpectomy, the
two-cut biopsy revealed fibroadenoma in a patient
yes,
of lobular carcinoma.
Yes, sir. It was done done outside. So
two-cut done outside, and
yes, sir.
And based on that, you did the excision, or the excision was done outside only.
No, so outside only, sir.
And then, so if the lump was excised, is there again the question of have you done a mammography to see whether it is a multicentric disease or unicentric disease?
No, sir. Mammography was not done.
And again, my point is now is a trend of breast conserving surgery. Even if it's a lobular carcinoma, if it's unicentric, then still there is a role for doing, because lump was excised. Definitely lump came as carcinoma, and then definitely they have not done a wide excision.
Yes.
And you said axilla was N0.
Yes,
so in your center, is there a facility for doing a sentinel node biopsy? No.
No, sir. I haven't seen, sir.
Okay. Dr. Bhattacharya, any comment?
Yeah. Bakhanda, good morning.
Yes.
Can I say a few words?
Yes.
Point one is, this is a common practice in India and in Calcutta. The patient gets a biopsy outside and they come with the report. One.
Yeah.
Two is we should review the slide. All the PGTs and students, because like surgery is specializing, pathology is specializing also. So we should select a pathologist who has got a oncopathological backup. So we should review all the slide with them and then plan for surgery. Two is the first surgeon who did a lumpectomy did not address the axilla. So some sort of axillary address, and this patient should be regrossed, because we should bring the tissue from the lab, because they usually keep the specimen in the lab up to 2 months or 3 months or 20 days or 15 days, depending on the lab's capacity. So we should bring the specimen, regross the specimen with a reliable pathologist, and then we should address the issue. If margins are clean, then we can only address the axilla for sentinel node biopsy because it is a lobular carcinoma.
That's
Over.
it's a margin may not be clean because if you've done the surgery with the diagnosis of fibroadenoma, probably you have not taken a margin.
Yeah.
You have done a surgery.
accept.
So
I
in
accept.
that case, a re-excision may be required, but I'm talking of whether
Just
in this situation
consultation.
also you can go for a BCS or versus mastectomy.
Mastectomy.
Okay, because you see the
point is,
rate of
Makoda,
mastectomy is going down.
Point
It is
is,
the
Makoda,
surgeon's choice to
Yes.
some extent of that unit also, and the patient's choice, combination too. So I think if the unit surgeon, anybody is there?
Makanda, I
Yes,
want to
yes.
highlight a point. Hello?
Yes, yes.
Point is, a patient who has coming 10-15 days post-operatively, it is very difficult to do a mammography because of the edema, swelling and things. Mammography will give you multicentricity in this particular case because this is not a screening or diagnostic, but it is very difficult to interpret the mammography because of the edema of the tissue.
No, but
Because-
ultrasound can, you see, if there is a,
but
there
ultrasound,
might be
yes,
some seroma or inflammatory change, but ultrasound
yes.
can make out a residual mass. But if you have excised this mass and probably you have excised the mass thinking it's benign, so it was not necessary that people have taken a wide margin out of that lump. So patient might need some form of re-excision.
Cavity
Or,
excision, cavity excision,
yes,
some
yes.
form of excision of the cavity and frozen section. Yes,
Yeah,
I
yeah,
accept your
yeah.
point.
Yeah.
Thank you. Over.
Thank you. Okay, we pass on to the audit for unit 2A.
Next, unit 2A.
So, I would like to invite Dr. Sayandi Pradhan, who will be presenting the audit for Unit 2A.
Okay, fine. Shandi.
Good morning, sir. Am I audible, sir?
Yes, you're audible.
Yeah.
Yeah.
Audible.
I am Dr. Shandi Pradhan presenting the surgical audit for the month of January for Unit 2A under Dr. Ochinto Das and Dr. Shivaji Mondal. Total OPD days 7, total admission days 3, total OPD patients 302. OT summary, total number of elective OT days 9, total time in OT, laparoscopic 22 hours, open 27 hours, total number of mortality 0. Elective admission 42, male 19, female 23, emergency admission 2, male 1, female 1, elective operation 30, male 17, female 13, emergency operation 4, male 1, female 3, minor operation 12, male 5, female 7. There was no mortality, there was no morbidity. Elective admission in hepatobiliary pancreatic surgeries, chronic calculus cholecystitis, laparoscopic cholecystectomy done, total 17, male 5, female 12. In appendicitis, laparoscopic appendicectomy done, 2 male, female 1, total 3. Fistula in ano, fistulectomy done, male 1. Anal fissure, lateral internal sphincterotomy done in male 1 male. Inguinal hernia, open inguinal hernioplasty, 6 in 6 male patients. Umbilical hernia, open umbilical hernioplasty in 1 male patient. Incisional hernia over Illusius scar, open incisional hernioplasty in 2 female patients. Sebaceous cyst over back, excision done in 1 male patient. Lipoma over right arm at medial aspect, excision done in 2 female. Emergency operations, obstructed incisional hernia, open incisional hernioplasty with mesh repair done in 1 female. In emergency admission that was managed conservatively, appendicular lump managed conservatively in 1 female patient. Gallstone pancreatitis managed conservatively in 1 male patient. Acute pancreatitis managed conservatively in 1 female patient. Minor operations done. Excision of sebaceous cyst from left side of back in 2 male, 1 female, total 3 patients. excision of keloid over anterior chest wall in one male patient and one female patient, total 2 patients. Left inguinal lymph node biopsy done in one male and 2 female patients, total 3 patients. Circumcision done in one male patient. Emergency abscess drainage from right middle finger pulse phase done in one male patient, 2 female patient, total 3 patients. There was no morbidity, there was no mortality. Thank you, sir.
Shayan, if I start with this, what do you mean by morbidity? You have operated 30 patients.
Yes, sir.
One emergency patient.
Yes, sir.
You see, any deviation from the smooth recovery is taken as morbidity. What you do is, in your day-to-day practice, you do not keep in mind these morbidities. Suppose you have done a lap cholecystectomy.
Yes, sir.
If the patient has excessive vomiting in the post-op period, that
Yes.
is also to be taken as a morbidity. Some patient may have excessive bile drainage. So it is unlikely that somebody is operating 30 cases and every patient has make perfect recovery is not usual. But idea of discussing this is, if you discuss the morbidity, you know how the patient deviates in the post-op period and what is the optimal management. Suppose you have a biliary drainage which is little more in lap function. How you have managed this patient? The idea of audit discussion is that suppose you have more of wound infections, maybe that 2, 3, 4% have wound infection in the month. So we'll try to discuss about why the infection has occurred, what could have been done, what is the bacteria being grown. Okay, so keep in mind next time when you take rounds, you keep in mind what problem has happened to some of the patients. It is good that if you have 30 patients being operated and 30 patients has no problem, no stitch abscess, no infection, everybody has perfect recovery is good. But you see, when you operate, there is some situations when everything does not go as per book teachings.
Yes, sir.
So there will be some changes in the outcome. So keep in mind that, and if you have mortality, try to describe that mortality, what was the underlying disease, what is the surgery done, what happened post-op, so that you can discuss something whether this death could have been averted.
Yes, sir.
And what else you could have done to avert this death. Okay, we are not doing post-mortem, but short of that, you can discuss that. Same with the morbidity.
Makanda,
Yes.
50 more than the 50% is GI upset. In each and every patient, it has been shown if there's a morbidity we are discussing,
Yeah.
more than the first is the what you rightly said, the nausea and vomiting. She couldn't start food, at least the liquids orally, at least within the 6 to 8 hours after laparoscopic surgery or any surgery. Second is other complication, even the delayed extubation, that is also another cause of the morbidity. So many ways the morbidity, not only like that, there's wound infection and fever, these are the...
Actually, our resident does not remember those at the end of month. So to present at the end of month, one has to keep a record that, yes, what happened to these weak post-op patients? They've gone smooth or they have some problems. Unless you keep a record, you cannot make out.
Yeah.
So it's good. You have more number of admissions. You have more number of OT days. Good. You can pass to the unit 2B.
Hello? Hello?
Yes, Dr. Prasad, please.
Dr. Prasad, Makanda, I have got a question here. The umbilical hernia, nowadays, a lot of people are doing laparoscopically with a laparoscopic mesh placement and thing. This is good. But we, the senior surgeons, are observing there are a lot of laparoscopic hernia operation, and then there is a dense adhesion in the abdomen while going for cholecystectomy. So, what is your message to the juniors? What is whether we should indulge on laparoscopic umbilical hernia repair? Because we have seen in several cases the port placement becomes difficult because of momental adhesion with the mesh.
No, Dr. Boshak, you see, if you go by recent trends in management, a laparoscopic approach is acceptable, but point is you should use a composite mesh, and then now you have newer approaches, like you can do a transabdominal retroratus mesh placement. In that case, we are putting a mesh outside the peritoneum, so that adhesion will be less. But the morbidity, the outcome of results of laparoscopic hernia repair is much better than open repair. That is you have to accept now.
Yeah, I accept. Open surgery usually causes much more pain and recovery is delayed. At least 3 to 5 days. I
Yes,
accept
yes.
that.
And
But
wound-related complications, Even if you do open mesh hernioplasty also, again you will find some additions will be there because you reduce the hernial contents. So some addition is expected.
thank you. Over.
Okay. You need to be. Yeah, you need to be.
Good morning, sir.
Yes.
Is my screen visible, sir?
Yes, visible.
Yeah, yeah.
Please.
Sir, this is the surgical audit for the month of January 2023 for Unit 2B, General Surgery in Ramkrishna Mission Seva Pratishthan. Sir, total number of OPD days 7, total admission days 8, total OPD patients are 218, total number of elective OT days 9, total time in OT planned surgeries, laparoscopic surgeries 32 hours, for open surgeries 4 hours, total time in minor OT 30 minutes, total time in emergency OT 45 minutes. Sir, total elective admission 23, among which 10 were male and 13 were female. Emergency admission 6, 2 male, 4 female. Elective operation 19, 10 male, 9 female. Emergency operation 1, he was male. Minor operation 2, 1 male, 1 female. Morbidity 1, sir. Among the surgery, for calculus cholecystitis, laparoscopic cholecystectomy was done for 11 patients. Among them, 3 were male and 8 were female. For fistula and fistulectomy were done. It was male. Inguinal hernia, totally extraperitoneal repair, TEP procedure was done for 4 male patients. For inguinal hernia, transabdominal peritoneal repair, TAPP procedure was done for 1 male patient. Bilateral inguinal hernia, open bilateral inguinal hernioplasty was done and mesh placement for 1 male patient. And supraumbilical hernia, supraumbilical mesh hernioplasty was done and she was female patient. Emergency operations are perianal abscess, incision and drainage was done and he was male. Among the emergency admissions are GB sludge with pancreatitis, obstructive jaundice and acute kidney injury. She was initially managed conservatively, but due to AKI and requirement of urgent dialysis, patient was referred to higher center due to non-availability of ICU beds in our hospital. And 1 acute calculus cholecystitis, she was managed conservatively. 1 cornerstone pancreatitis, she was managed conservatively. 1 male patient with deep scalp laceration and scalp hematoma was managed by primary wound care stitches followed by conservative management. Among the minor procedure performed, excision of CVCS cyst for 1 female patient. There is only 1 morbidity, no mortality, sir. The morbidities of 30-year-old female patient was diagnosed as supraumbilical hernia, for which she had undergone supraumbilical mesh hernioplasty. Only mesh repair was done, and on postoperative day 7, superficial epidermal blistering was noted, and subsequent dressing was done during the hospital admission and even after the discharge during the follow-up visit in the OPD, and no seroma or SSI were diagnosed, and improvement has been noted clinically. Thank you.
If I start with your patient of gallstone pancreatitis, you said you have done conservative treatment. What is the recommendation for treatment for patient having gallstone pancreatitis?
Yes, sir. For gallstone pancreatitis,
When patient should undergo cholecystectomy? What time you plan for cholecystectomy in this patient?
yes, sir. Sir, after initial management, sir. So first for these patients, sir, MRCP was done, and he was diagnosed with CBD stones, and subsequently ERCP was done, and he was discharged. And after 6 weeks,
Is that the
laparoscopic
recommendation?
cholecystectomy.
Patient, is that the recommendation? You have done a MRCP which reveals CBD stone. Same admission, you have done the CBD stone extraction, and you discharge the patient. That is not the standard of care. Standard of care should be patient should undergo cholecystectomy in the index admission. Otherwise, patient has again the risk for recurrent gallstone pancreatitis. Okay, so that is
Okay,
one
sir.
important
Okay.
thing. And another thing I find good part is whole RKM has no mortality in a month, and mortality is a index that how critically ill patients you are treating. So if you have no mortality, and that indicates all the patient has good outcome, and second is that indicates that critically ill patients are less. Because if we treat more of critically ill patient, there will be some mortality. What do you feel,
Yeah.
Dr. Bhattacharya?
Yeah. Most of the patient in our hospital, actually critically ill patient, the emergency admission is very less, very less.
Okay.
So critically ill patients, most of the day comes on an emergency basis. But in our
Okay.
hospital, the emergency patient is very less due to the two reasons. Nowadays, previously we used to have the emergency operation at least 2 to 3 per day. But problem is the people, I think the monetary expenditure, the problem, that's why people are coming to the government hospital and they are not coming in our hospital. You see, the most of the cases we have done the elective operation. One or two cases
Yes.
which has come in our
Less.
emergency.
Yeah.
So that is the problem.
Okay.
Hello, Makonda, can I add
Yes.
two lines?
What about?
In
Yes.
our hospital, we do spend a lot of time in elective operations, but emergency operation is basically a teamwork. Because if you want to take high volume and challenging cases, you should have a very good teamwork with the surgeon, assistant, anesthetist, and the ICCU team.
Yes.
Because it is a
That's true.
charitable trust, this association is little bit lacking, and patients do get frightened to admit in the hospital, because although the charge is less than nursing home and corporate hospital, but still then for a volvulus it will cost 30 to 40,000 rupees. So those who are amicably agreed for the operation, we operate on those patients like mastectomy, laparotomy, volvulus,
Yeah.
but we do say clearly that it will cost you around 50,000 rupees. So if you want to be here, and nowadays in this post-COVID scenario, a lot of patients are flying away. Patients are coming, we are talking, but we are not able to convert them for operation. That is the main issue. Because in Ramakrishna Mission, it is although it takes some amount of money, that may be heavy for their pocket.
Actually,
Yeah,
the
we
cost
do
of
try.
medicine is very high. The cost of medicine is very high. That is the problem. Cost of medicine is very high in each and every case.
Yeah.
And if you will end up into a very high grade antibiotic, then it is a problem. Because one vial costs 100 rupees.
Elective surgery load is very good. The elective surgery part is very good. Laparoscopic cholecystectomy, hernias, anal cases.
That is, so we are surviving only with the elective operation, but emergency operation is very few.
We will gear up it soon.
And secondly,
We have taken 4 registers now. Post MS and post DME, we will gear up within 2 to 3 months.
Yeah.
We have appointed Maharaja has agreed. So with the help of SR, we will gear up in 2 to 3 months. We have got a plan to gear up the system in 2 to 3 months.
Sure.
And one thing I want to mention.
MR Bangur audit will be, there are 3 presentations. Unit 1 will be presented by, I think, Dr. Mehul. Unit 1
So
will be
Dr.
by
Prasanjit, sir. Yes, sir.
Yeah. Prasanjit, please share your screen and quickly present.
Good morning, respected sir. I am Dr. Prasanjit Basu, Unit 1, MR Bangur District Hospital, I am going to present surgical audit for January 2023. Our total OPD days are 10, total admission days are 12, total OPD patients 1230, which includes old patient
Prashanjit,
492.
if I hold you now, how can be
Yes.
10 OPD days? 2 admission days in a month, 10 OPD days? Are you sure?
Yes, sir.
10, huh? Okay, fine. Carry on.
Old patient includes 492 and new 738. Total number of elective OT days 8. Total time in OT. Table 1 lab, which includes 30 hours 30 minutes. Table 2 open, which comprise 43 hours and 30 minutes. And total number of minor OT days 12 and total number of mortality 1. Elective admissions we have 37, in which 17 male and 20 female. Emergency admission we have 23, in which 10 male and 13 female. Elective operation 35, in which 15 male and 20 female. Emergency operation we did 16, in which 10 male and 6 female. Mortality, a single case of mortality, female case. And the morbidity, single female case. Elective operation and admission we did chronic calculus cholecystitis 11, in which we did laparoscopic cholecystectomy. 10 2 are male and 9 are female, and open cholecystectomy we did 3 cases, all 3 are female. GI and perianal cases, in which fistula in ano, in which we did fistulectomy, total 2 cases, 1 male and 1 female. Recurrent appendicitis, appendectomy we did 2 cases, 1 male and 1 female, and laparoscopic appendectomy we did in single female case. Hernia and groin surgery, umbilical hernia, in which we did sorry sir, by mistake it is there in anatomical repair done in this umbilical hernia. I think wrong slide. In umbilical hernia we did mesh herniaplasty in single female cases, and incisional ventral hernia we did mesh herniaplasty at a single case, and inguinal hernia 7 cases, in which we did like instant tension-free mesh repair, and inguinal hernia herniorrhaphy we did 2 in 2 cases. Circumcision we did in 2 cases, and nephrectomy in a case of left-sided hydronephrosis 1, and in split thickness skin grafting done in 1 cases. Emergency operation we have obstructed inguinal hernia, in which a mesh hernioplasty done, and in acute intestinal obstruction exploratory laparotomy. Sir, I think I have to share the slide.
Prashanjit, you are not audible. Prashanjit, you are not audible.
Professor Saha, Dr. Basak here.
Yes.
Can I discuss a few points?
Yes.
We are taught that obstructed or strangulated hernia, we should not put mesh. But here they have shown they have put a mesh. How do comment on this?
No, obstructed you can put. Obstructed you can, strangulated you should not put. Obstructed inguinal hernia you can put a mesh. That is not a problem. In strangulated you should not put a mesh.
Problem is in obstruction or strangulation, we don't know the amount of bacterial load and transmigration of bacteria from the intestinal wall to the ear. Because I remember one case in my life where I went to operate and did a obstructed hernia, and then I put a mesh, and it got seriously infected. It got seriously infected, and I had to take the mesh out. So that's
That's
one
true, Dr.
incident.
Bhattacharya, but now
That is the
recommendation is that that is true, but the recommendation is if there is a strangulation, you should not put a mesh. If you are doing gut resection, you should not put a mesh. But a simple obstruction, you can drain the toxic fluid, clean it up, and then you can put a mesh. That is there. Non-strangulating.
Because Makonda, antibiotic era has come now, so we can give the higher antibiotic. Thanks to antibiotic, that's why we are using, and the most of the cases we are not getting in the problem.
Yeah,
But
but
you rightly
strangulation, you
say
should not
the
put a mesh.
strangulation, yes. Strangulation we are not supposed to put.
Yeah. Pushinji, there is shortage of time. You carry on.
Yes, sir. Obstructed inguinal hernia, in which we did mesh hernioplasty in single case, acute intestinal obstruction, in which exploratory laparotomy done with right hemicolectomy, and rupture splenic abscess was there, in which we did splenectomy. Acute appendicitis, in which we did have open appendicectomy, and in perianal abscess, we did ID under TIVA, and in diabetic foot ulcer, we did debridement under local anesthesia. 7 cases are there. Minor operation within excision of pyogenic granuloma.
Okay. Skip minor operation. Go to the next part.
Morbidity, we have single morbidity case, and mortality, we have single female mortality case. Morbidity, a 32-year female patient who is a post-op case of open appendectomy on POD5 develops seroma, which is managed conservatively by dressing, and swab sent for culture antibodies come out negative for any growth.
Okay.
Mortality, single mortality case, a 56-year female who presented with subacute intestinal obstruction was initially managed conservatively and on workup found to be ileocecal mass. Patient was preoperatively optimized and patient underwent right hemicolectomy with double barrel ileostomy. Post-operatively, patient was doing well except seroma formation in wound, which was managed conservatively on POD6. Patient developed severe respiratory distress with saturation below 80%. Patient was tried to manage inward with oxygen therapy and other conservative management. As patient is not responded, patient is shifted to CISU and patient is intubated. But patient eventually develops cardiac arrest and succumb to death.
Prasanjit?
Yes, sir.
Good morning, sir. Is this patient the same that you saw in emergency operations?
No, sir.
This is a different right hemicolectomy.
Yes, sir.
Hey, these are patient in emergency. They have shown as obstruction under right hemicolectomy.
But here you have mentioned that the patient was optimized and put up for OT later on. Then how is this an emergency operation?
Sir, initially the obstruction was not so much. It is subacute level, but gradually the obstruction is turned into acute condition.
So what is the consequence? What do you think is the cause for respiratory distress in this patient?
Sir,
there is no wound related complication.
No, sir. Just minor seroma is there.
Fine.
It may be due to.
Yes.
It may be due to pneumonitis develops on subsequent POD days.
Have you examined the patient lower limb to exclude DVT or did a Doppler study of the lower limbs?
Sir, it cannot be done. We did not do that.
Because you see, one reason for development of acute respiratory distress should be a DVT leading to pulmonary embolism, because that is one of the important cause of very fast deterioration of the patient. Okay, if you have
we added such prophylactic LMWH for this patient.
When she was on this?
For POD 1 to 5, we added, sir. Okay. Prophylactically, we added.
Acha. She was on LMW.
Yes, sir. Yes.
Hello, Mahanda, can I add one point?
Yes. Yes.
Did you do a blood culture? Because a patient who is septic and succumbed and developed hypoxia, pneumonitis, pulmonary aspiration, infection, these are common. But did you do a blood culture to assess the, because the patient has got seroma, patient has got a obstructed abdomen. So septicemia is a common, and particularly in septicemic patient, the patient goes rapidly downhill. Particularly this sort of patient who are poor socioeconomic status, poor nutrition, because operation is very simple. You did a right hemicolectomy. And what was the histopathology? Did you talk to the pathology department? What was the histopathology of this patient?
Sir, it turns a malignancy, ileocecal mass, and the adenocarcinoma of colon is detected later on that.
Okay.
I don't know.
And what was the stage of this patient? T staging, did you do it?
Obstructing mass, it should be at least T3 or T4.
Yes,
It's obstructing mass.
Yeah,
And
that
what was
is
the
not
size of the
case in
tumor?
patient.
What was the size of the tumor?
It was, sir, quite large, sir. It is around 5 into 5 centimeters.
Okay. Thank you. Over. No, over.
Post-operative X-ray chest, was it done?
Yes, sir.
Chest evaluation post-operative. Because this patient was initially subacute intestinal obstruction, the repeated vomiting, patient might have aspirated. So that's why X-ray chest evaluation was done.
Yes, sir. It shows some pneumonatic patches, bilateral pneumonatic patches.
Only pneumonitic patches, patient shouldn't die. Is there any something else? Okay, fine. So,
Sir, post-distress chest X-ray was done, sir, and the left-sided chest, lung was completely white, sir.
yes, yes,
because
that is the, yes. Okay, that can be the cause. That can be the cause.
One thing I want to highlight here, the aspiration pneumonia usually occurs on the right side because the right bronchus is more straight from the trachea, and left-sided infection may not be the aspiration. Aspiration usually occurs on the right side, although according to his history in the left side. Okay, thank you. Over.
So I think next unit, Makonda.
Sir, you're on mute, sir. Sir, you're on mute.
Yeah, Mehul, please start.
Good morning, respected professors and seniors. I'm Dr. Mehul Patel, first year DNB PGT. I'll be giving the surgical audit for Unit 2 General Surgery of MRBH of January 2023. Total OPD days 9, total admission days 10, total OPD patients 1,157. Total number of elective OT days 9, total time planned in OT, table 1 lab 33 hours 15 minutes, table 2 open 40 hours 40 minutes. Total number of minor OT days 10, time in minor OT 9 hours 30 minutes, total number of mortalities 1, total number of morbidities 0. There were total 46 elective admissions, out of which 25 were male and 21 were female. 29 emergency operation admissions, out of which 18 were male and 11 female. 34 elective operations, out of which 21 male and 13 female. 22 emergency operations, out of which 15 were male and 7 were female. Total minor operations were 31, 1 mortality, which was male. In hepatobiliary and pancreatic and splenic surgeries, there were total 12 cases of chronic calculous cholecystitis, out of which 10 were operated laparoscopically and 2 were open cholecystectomy. And 1 case of carcinoma GB with metastasis, which was referred to higher center. In gastrointestinal and perianal surgeries, 1 colostomy reversal was done, which was male. 1 fistulectomy and hemorrhectomy was done for fistula and NO with internal hemorrhoids. And 1 open appendectomy was done for recurrent appendicitis, which was male. In hernia and groin surgeries, 1 TAP was done for unilateral inguinal hernia male. 2 Liechtenstein mesh hernioplasty was done for inguinal hernia. 4 herniorrhaphies were done for inguinal hernia. 2 anatomical repair was done for epigastric hernia. 1 anatomical repair was done for umbilical hernia. 1 TAP plus was done for umbilical hernia. 1 Jaboulet's procedure was done for bilateral vaginal hydrocele, and 4 circumcisions were done for phimosis. In breast and endocrine surgeries, 1 subcutaneous mastectomy was done for unilateral gynecomastia, which was male, and 1 excision of fibroadenoma was done. In emergency admissions, exploratory laparotomy with Graham's patch repair was done for peptic perforation. In a case of liver abscess and pleural effusion, pictal catheter and ICD was done. Debridement was done for foot ulcer. Incision and drainage was done for submandibular abscess. 4 cases of incision and drainage for perianal abscess. 1 case for incision drainage for subclavicular abscess, and 1 breast abscess. Incision and drainage was done. 1 case of acute gallstone pancreatitis, which was managed conservatively. 1 case of acute alcoholic pancreatitis, which was also managed conservatively, and 1 case of acute calculus cholecystitis, which was also managed conservatively. 6 appendectomy was done for acute appendicitis. 1 case of subacute intestinal obstruction, which was managed conservatively. 1 case of stab injury, which was locally explored and repaired. 2 cases of foot cellulitis, which were managed conservatively, and 2 cases of diabetic ulcer, for which debridement and dressing was done. Minor operations and emergency interventions. 7 sebaceous cyst excision was done.
Okay.
5
Skip minor operation. 27 total. Next.
2 minor procedures. 2 chest drain insertions were done. Mortality, 1 male. 55-year-old male who presented in the emergency with features of peritonitis and septic shock, with a history of 7 days. On presentation, his BP was 80 by 50 mmHg, heart rate was 140, and SpO2 was 80%. His urine output was negligible. Initial resuscitation was done, but the patient was non-responder. ABG was done, which showed metabolic acidosis. Patient was shifted to ICU and was started with noradrenaline support and ventilated, but after 2 hours, the patient developed cardiac arrest and succumbed to death. Thank you.
What was the diagnosis? Peritonitis means what? Did the patient have free gas on the diaphragm?
Yes, a gas under the diaphragm was this.
So it was 7 days history.
Yes, sir. He was having pain from the past 7 days, after which he went to some local doctor. He was then went to some local doctor, and then after which he then he went to a nursing home for where he was treated for some time, and then he took LAMA, and the patient came in the emergency.
Oh, okay. In hernia, I find you have done a lot of anatomical repairs.
Yes,
what
sir.
is it? Dr. Abhishek is there? Dr. Abhishek is online? No.
No, sir.
How do you select that you put a mesh or do anatomical repair? What is your innate strategy? Yes.
Sir,
Nitesh.
it's a surgical preference of the consultant, sir.
Okay. So you can oppose without tension.
Yes, sir.
What I'm trying to say is, what is the gap that you decide, yes, you'll do anatomical repair or you place a mesh? It is surgeon preference.
For small gaps, we do anatomical repair, small defect, and for larger defects, we push less.
Okay. No, Abhishek is not in line. Chalo, theek hai. We'll pass on to the next presenter.
Makunda,
Yes,
with
yes.
your permission, can I leave as because we are having OT?
Yes. Okay, last presentation. Yes, please.
Mahunda, what are the cause of 2 open cholecystectomies in the era in your unit? Yeah, you are there. Why they do this 2 open?
I'm in it 3. Mine is next. You see, some patients are offered open because what I do is I need my PGs to get trained up in open surgery also.
Okay, that's
so yes, you cannot place all for lab. Some has to go for open also.
No,
Next
that is That is a
My
good
next
point, Makunda.
presentation. Yes.
They should learn the open technique also, because when
Yes,
the
yes.
lab fails, this should be our motto also. Each
Yes.
student before leaving should practice 2 or 3 lab open coli.
Yeah.
Good
Yeah,
idea. I
Yeah.
accept it. Thank you.
Not only that, Makunda, I should say in this laparoscopic era, Bosak
Yeah.
said, in our unit also we have done that one. And because all drugs, so patient is hypersensitive to the drugs. That is general anesthesia drugs. So we were bound to do the cholecystectomy under epidural anesthesia.
Yeah. You should
Thank
do
you.
some open surgery for training our PGs. Okay,
Yes,
last
yes.
presentation. Come on, quick.
মাখনদা আমি লাস্ট পরে একটু কথা বলে নেব, কোন দিন আসতে পারবেন আপনি একটু?
I'm Dr. Diptaman Nandi, first year in the PGT, MRBH, General Surgery. I am going to present the General Surgery Unit 3 audit for January 2023.
Diptaman, you are not audible.
Come closer. Yes.
Audible now, sir?
Yes.
Hello.
Yes, you're audible.
Summary,
Carry on.
Total OPD days 8, total admission days 9, total OPD patients 918, which includes new patients 672, old patients 246. Total number of elective OT days 9, total time in OT, table 1, 28 hours 20 minutes, table 2 open 33 hours 15 minutes, total number of minor OT days 9, including time in minor OT 12 hours 25 minutes and time in emergency OT 3 hours. Total number of mortalities was 2. In audit January 23, this tabular form, elective admissions were 44, emergency admission 9, elective operation 40, emergency operation 3, minor operation 47, mortality 2, and morbidity 1. In hepatobiliary and pancreatic surgery, chronic calculous cholecystitis, 13 cases were there which underwent laparoscopic cholecystectomy. Chronic calcific pancreatitis, phase procedure was done in a male patient. Carcinoma gallbladder case was treated with diagnostic laparoscopy with palliative cholecystectomy. This was a female patient. Then another case of carcinoma gallbladder, male patient. Diagnostic laparoscopy with radical cholecystectomy was done. There is a case of carcinoma head of pancreas which underwent Brussels operation. And there was a case of choledosis which underwent hepatogeninostomy. In the gastrointestinal and perianal section, C-rectum case was there. One male patient who underwent duodenal anastomosis with feeding jejunostomy with ileostomy. There was a case of subacute intestinal obstruction which underwent diagnostic laparoscopy followed by damage control surgery. This was a male patient. Fistula in ano cases was 2 which underwent fistulectomy case. There was a follow-up case of Hartmann procedure. This was the Hartmann procedure was done from outside and the patient was admitted here for the reversal. This reversal of Hartmann procedure was done, but this patient was again reoperated or re-explorated who underwent ileostomy. In the hernia and joint surgery section, umbilical hernia case was one male patient underwent IPOM plus. There was a case of bilateral inguinal hernia who underwent mesh hernioplasty. There was case of incisional ventral hernia underwent mesh hernioplasty and abdominoplasty. Inguinal hernia, right inguinal hernia underwent staph hernioplasty. There are 4 cases of lateral mesh hernioplasty. There was a case of mesh infection which was extracted from right-sided inguinal hernia. Umbilical hernia case was 1, underwent mesh hernioplasty, and there were 2 phimosis cases which underwent circumcision. There was a case of hernioplasty, 1 male patient underwent 6-month operation, and there was a case of female right adrenal adenoma who underwent excision. In the emergency operation case section, there was 2 ulcers, 2 cases underwent incision and debridement, and 1 case of inguinal in perianal abscess who underwent IND. Now, emergency analysis Boston pancreatitis cases was 1 male who was given conservative management, 2 cases of acute calculous cholecystitis who was given conservative management. There was a case of leptic cellulitis with T2GM and HTN underwent conservative management, and 2 cases of diabetic foot ulcer who were given debridement and dressing. Now, these are the list of minor operations.
Skip.
Regarding morbidity and mortality section, there was a case of one morbidity and two mortality, which I am discussing in the subsequent slides. This morbidity case, this patient was 40 years male patient, was admitted for reversal of Hartmann procedure. This Hartmann procedure was done on the outside, but he was admitted here for the reversal. POD1 was uneventful, but since POD2, he started having such distension of abdomen and pumping of pain abdomen. He was continued on 19 on IV antibiotics and fluids. In POD3, he started having distress from the OT side, which continued for the coming days in spite of daily basis and other supportive management. So it was decided for re-exploration, and re-exploration was done on day 7 from the date from reversal of Hartmann procedure. The patient is still admitted now in our ward, but he is now gradually improving. His discharge is also decreased, and the patient is quite fine and satisfied now. Next, in the mortality section, these are 77-year male who underwent a simple procedure for periampullary carcinoma. Preoperatively, the patient was optimized with hemoglobin 11.2, albumin 3.8. Patient was also sensitized to spirometry and test physiotherapy. Intraoperative period was uneventful. Postoperatively, patient was shifted to ICU. Patient initially maintained normal vitals and oxygen support. Brain output was less than 50 ml. Nebulization, intensive spirometry, test physiotherapy, and DVC stopping was started from day 3. POD1 urine output was 450 ml with mild dehydration. Blood parameters were within normal limits with LFT showing improving trend, so it was altered accordingly. On POD2, urine output increased, gain in HRP and 80 ml with bile staining, albumin 2.5, albumin was transient. In POD3, urine output increased to 850 ml, serum then 75 ml, bile staining still present, blood parameters within normal limits. But on the POD5, urine output also was in 1750 and then 150 ml bile with mild discharge from one side. POD7 case decreased in base and ACN drain was 50 ml. Patient is ambulating, oral decreased 50 ml per hour, blood parameters within normal limits. In POD9, chest and LT improved, per abdomen soft, ICU stars, taking PR fluid with 1 amount orally, FG speed at around 2 liters per day along with PL. Patient is ambulating, HRPM 10 ml, serosanguinous. On POD11, patient develops mild respiratory distress, SpO2 90% on room air, started on O2 with nasal cannula. On POD12, chest obstructive pneumonia, patient requiring oxygen. On POD14, patient develops alkalosis requiring oxygen at the rate of oxygen at the rate of 70 liters per minute. Total count around 14,300. On POD15, patient was intubated again with pressure control mode. Hypotension developed, so patient was given NORAD support, and also urea creatine level was increased, and patient developed AI. On POD16, patient succumbed to respiratory complications. In mortality, this was a 65-year-old.
Okay, Deeptaman.
Yes, sir.
Carry on. Okay. Finish up the second case.
In the mortality too, this was a 55-year-old male with diagnosis of SCA sigma grade 1 and underwent explorated laparoscopy with a plan to proceed to LAR. Preoperatively, patient was optimized. Intraoperatively, tumor mass was infiltrated beyond the serosa of the sigmoid and colon was adherently posteriorly to underlying structure and securely to part of the duodenum. On initial manipulation to ascertain the extent of tumor local spread, the fibrous tumor tissue from the duodenum to sigmoid was damaged. Primary repair at both sides were done with FG and ileostomy, and further procedure abandoned due to unresectability. Post-operatively, the patient was shifted to IT. Patient maintained initially normal.
Deeptaman, you are on mute.
Nebulization, intensive spirometry, limb and chest physiotherapy, and DVC stoppings were started by day 3. In POD1, hemoglobin was 70.7 and 1 unit of PRBC was transfused. On POD2 and 3, vitals were stable with parabdomen soft, IPS present, stomatoid functional. Nebulization was given along with intensive spirometry, limb and chest.
Deeptaman, you are not audible. Hello, Deeptaman. Sir, I'll continue on his behalf, sir.
Yes, yes. Dipta.
Yes, sir.
Uh,
On POD6, the discharge from wound side increase and appears frequent. Abdominal wound was opened and about 500 ml of frequent wound material drained out. On POD7, patient was again shifted to patient control mode of ventilation after intubation and started on urological support. On POD8, unfortunately, patient succumbed to these complications.
Okay. Diptaman, he has given a very good outline of the patient death from the post-op period to the death period. That is a good way of analyzing the death. So the first death was probably due to some respiratory complication of the increasing age, and patient was confined to the bed. So Dr. Boshak is there? Any comment?
Yes, yes. I'm hearing. Mahonda.
Yes, yes.
Most important thing in our country, you have to consider we are doing big operations in a socio-economically compromised patient, and their nutritional status and other status are usually poor in government hospital. So, these things can happen. But a good thing is that you are still doing big cases with all the limitations. That is a commendable work. That is the point one. Point two is that one thing that the Whipple's patient may die because of several complications. That is a point that I don't mind. And reversal case may leak because I have got 1 or 2 experience of leak of reversal, and this is very painful because patient comes for to get rid of colostomy and goes back with a colostomy again. So that is very painful experience for the surgeon and the patient too. And third thing is that I wonder what was a CT scan report, because you planned for a low anti-dissection and then once you opened and you saw the duodenum is infiltrated. So I think they did a CT scan and staging. That CT scan should be critically reviewed. These are 3 points from this audit from my point of view.
Yes, yes. This was a very advanced growth actually. CT scan. Yeah.
So in this case, I would have advised to go for a colostomy, proximal colostomy, and chemotherapy. I would venture for surgery.
Agreed. Actually, this was a situation that just on handling this area got opened up. This should not have been done, because if you see the mesocolon getting infiltrated, it was not desirable to proceed further. But somehow this accident happened, which should have been avoided.
We should have done a simple colostomy, and whether the duodenal obstruction is there an obstruction at the duodenal level where it has infiltrated?
No, it was not.
And then we could have downstage it with chemotherapy, and then we could have salvaged the
that was ideal case for that. Yes, our proceeding was a wrong decision in this patient. Agreed.
Agreed. Thank you.
Okay.
Thank you. Thank you. We had a nice discussion. Thank you, everybody. Thank you, everybody.
Thank you.
What a nice discussion. Thank you.
Thank you.